Now we'll move to lipid autocoids. Lipid autocoids. First of all, how lipid autocoids, that means prostaglandin-like substances, are synthesized. All of them are synthesized from phospholipids present in the membranes. Phospholipids are metabolized to form arachidonic acid. The enzyme involved is phospholipase A2. Now this arachidonic acid, if cyclooxygenase work, form prostaglandins, and if lipooxygenase work, it form leukotrienes. Now leukotrienes initially formed is leukotriene A4, which is unstable and quickly broken down to form leukotriene B4, or it forms leukotriene C4. Leukotriene C4 is converted to leukotriene D4 and E4. On the other hand, prostaglandins initially formed are G2 and H2, which are unstable, and they will form different end products in different cells. In the platelets, they form thromboxane A2. In the endothelium, they form PGI2. And in other cells of the body, they form prostaglandin D2, E2 and F2 alpha. So these are the formation of different prostanoids or prostaglandins, we can say.
If you note, leukotrienes, they contain the subscript as 4, leukotriene A4, B4, C4, D4. Whereas prostaglandins, they contain the subscript 2, PGG2, H2, thromboxane A2, PGI2, D2, E2, F2. So what is the meaning of this subscript? What is this 2 or what is this 4? Yes, these are the number of double bonds. Remember, arachidonic acid is a 20 carbon fatty acid. It contains 4 double bonds. And all the 4 double bonds are intact in leukotrienes because it is a straight fatty acid and leukotrienes are also straight chain. On the other hand, when cyclooxygenase work, from the straight chain fatty acid a cycle is made, and during the making of this cycle 2 double bonds break. So prostaglandins have only 2 double bonds. So all the endogenous substances, endogenous prostaglandins, they contain 2 double bond. But when we synthesize these compound in the laboratory, then we can make the compound with 1 double bond also. So particularly we have drug like misoprostol, and we have another drug called as L-prostadil. They are actually prostaglandin E1. They are prostaglandin E1. They are synthetic compound. They contain 1 double bond only, but they work like endogenous prostaglandin E2. Their function is exactly same like prostaglandin E2, but chemically they are prostaglandin E1. Clear?
Now coming to action of these prostaglandins, leukotriene B4, the major function is chemotaxis. So it is involved in causing inflammation. Leukotriene B4 causes inflammation. On the other hand, leukotriene C4, D4 and E4, they are powerful bronchoconstrictors and they are major mediators in human bronchial asthma. C4, D4 and E4 are involved in bronchial asthma. B4 is involved in inflammation. Now coming to prostaglandins, first of all we will discuss the functions of prostaglandins. We all know prostaglandins are involved in causing fever, pain and inflammation. That's why if we inhibit the cyclooxygenase enzyme by drugs like aspirin, we can get these 3 effects. That means antipyretic, analgesic and anti-inflammatory effect. So prostaglandins are involved in causing fever, pain and inflammation. We discussed earlier effect of prostaglandins on platelets. In the hematology we covered this thing. 2 prostaglandins have opposite effect on platelets. These are thromboxane A2 and PGI2. So you can easily remember thromboxane A2A for aggregation. It causes platelet aggregation, whereas I means it will inhibit the aggregation. So thromboxane A2 cause aggregation, PGI2 cause inhibition of aggregation. When we give aspirin-like drug, which is inhibitor of COX and which is irreversible inhibitor of COX, initially both thromboxane A2 and PGI2 decrease. But because thromboxane A2 is produced by platelets which do not contain the nucleus, so new COX cannot be synthesized, so its production remains suppressed. On the other hand, when PGI2 synthesis occurs, COX inhibition will stop its synthesis, but after some time, because of presence of nucleus in the endothelium, new COX enzyme is synthesized and PGI2 can be formed again. When cyclooxygenase is produced, PGI2 again can be formed. So the net effect is there is decrease of only thromboxane A2. That's why it is used as antiplatelet drug. So this is effect on the platelets. Then effect on cardiovascular system. Cardio, first of all, heart. If we see, we have 4 chambers of the heart. 4 chambers of the heart. Aorta originate from the left ventricle and supply the blood all over the body. Pulmonary trunk originate from the right ventricle and supply the blood mainly to the lungs. Now the circulation is similar before birth and after birth. The only important difference being, before birth the lungs are not mature. When the baby is inside the uterus, the lungs are not matured. So that means the lungs do not contain air. So when the lungs do not contain air, the blood vessel which is coming in this area will feel high pressure, and this is the problem in intrauterine period. The pressure in pulmonary circulation is very high. The pressure is so high that there is a risk of rupture of pulmonary trunk. So to prevent this risk of rupturing, there is a communication between pulmonary trunk and aorta, and this communication is called as ductus arteriosus. So before birth, there is a tube called as ductus arteriosus, which is connecting the pulmonary trunk and aorta. So some of the blood from pulmonary trunk can shift into aorta, reducing the pressure here. So the vessel will not rupture. This is a protective mechanism. And this ductus arteriosus is kept open by prostaglandins, particularly PGE2. Prostaglandins like PGE2 keep the ductus open. Now when delivery occurs, now the formation of prostaglandins is not there. So when prostaglandins are not there, the ductus will close. And this is the thing we want, because after birth the lungs contain air, so pressure in the pulmonary circulation is less, and after birth the pressure in the aorta is more than pulmonary trunk. So if the ductus remain open, then some of the blood will come back. So instead of going all over the body, some of the blood will come back, that will produce the symptoms of low cardiac output. So we do not want these symptoms, and physiologically the ductus closes. So that's why these symptoms do not come. So we want to keep the ductus open before the birth, and we want it to close after birth, and that happens because prostaglandins are produced before birth and not after birth. Now there are 2 types of problems which can occur. The first problem is the ductus remain open even after birth. So the condition is called as patent ductus arteriosus, PDA. The name tells ductus arteriosus is patent even after birth. So in this condition we want to close the ductus. And closing the ductus, we have 2 methods. One, we can open the heart and ligate by the thread. Obviously cardiac surgery is not so simple, so we want it to do by drugs. So second thing we can do is we can give the drugs, and the drugs which we can use for closing the ductus are those which inhibit the formation of prostaglandins. And which drug inhibit the formation of prostaglandin? Yes, aspirin-like drugs. So we can give the drugs like aspirin, indomethacin, or ibuprofen. So all these drugs, they can be used for treatment of patent ductus arteriosus. The second problem that can occur is a baby is born with a congenital malformation called as transposition of great vessels, TGV. As the name tells, great vessels means aorta and pulmonary trunk are transposed. That means aorta, instead of originating from the left ventricle, is originating from the right ventricle, and opposite for the pulmonary trunk. This condition is not compatible with life, so it has to be surgically corrected. That means we have to cut the aorta from the right ventricle and place it on left ventricle. Same we have to do for pulmonary trunk. But when we cut one vessel, we want that the ductus should remain open so that the blood can shift into other vessel and problem in surgery does not occur. So we want that till the time we are doing the surgery of TGV, the ductus should remain open. But normally ductus arteriosus will close. So here we want to keep the ductus open. So for keeping the ductus open, we have to give prostaglandins. So PGE2 is given to keep the ductus open. And the drug which is PGE2 analog is L-prostadil. L-prostadil. It keeps the ductus open, and from the name you can remember in Hindi, it is prostaglandin acting on dil. Prostaglandin acting on dil is L-prostadil. So this is about effect on the heart. So ductus arteriosus is kept open by prostaglandins. Now coming to effect on blood vessels. Prostaglandins, again particularly PGE2 and PGI2, that means prostacyclin, these are powerful vasodilators. And their vasodilatory action we are utilizing in treatment of pulmonary hypertension. In treatment of pulmonary hypertension, we are giving the drugs like iloprost, which is PGI2. It causes dilation of pulmonary vessels, which will treat the pulmonary hypertension. So this is effect on cardiovascular system. The next is effect of prostaglandins on the uterus. Effect on the uterus. The upper segment of the uterus is stimulated by PGE2 and PGF2 alpha. PGE2 and PGF2 alpha contract the upper part of the uterus, whereas prostaglandin E2, it relaxes the lower segment of the uterus. Upper segment is contracted but lower is relaxed by PGE2. And this thing we can utilize in abortion. So we can use prostaglandin E2 for inducing the abortion, because what we want in abortion is we want to contract the uterus from above and we want to relax it from below so that product of conception can easily go out. So we can use PGE2 for abortion, and the drug which we are using is misoprostol. So misoprostol is PGE2 derivative which can be used for abortion. Now another thing, this is uterus, placenta is attached on the uterus. Over the placenta baby is attached. So when the delivery occurs, first the baby goes out. After the baby goes out, the placenta goes out. Now when the placenta goes out, the blood vessel which were connecting the placenta to the uterus, they become free. blood vessels become free. So the bleeding starts. Normally, this bleeding stops after some time because of uterine contractions. When the uterus contracts, the blood vessel will get pressed between the muscle of the uterus, so that will stop the bleeding. But in some cases, uterine contractions are not very strong, so the bleeding continues. And this bleeding is known as postpartum hemorrhage, short form PPH, postpartum hemorrhage. So for treatment of postpartum hemorrhage, we have to contract the uterus. If the uterus is contracted, PPH will be treated. So we can utilize the drugs like carboprost for treatment of postpartum hemorrhage. Carboprost, which is PGF2 alpha, can be used for postpartum hemorrhage. But remember, the drug of choice for PPH now is oxytocin. Oxytocin also do the same thing, contract the uterus, and it is a physiological substance, so much more safer. Oxytocin is a drug of choice for PPH. Now misoprostol, which we were discussing, we can also use intravaginal misoprostol to relax the lower segment. And this relaxation of lower segment is termed as cervical ripening. So during the time of labor, if dilatation of cervix is not much, we can use intravaginal misoprostol to dilate the lower segment. That means we can induce cervical ripening. So that are the uses of prostaglandins on the uterus. Prostaglandin, again PGE2, it protects the stomach from the peptic ulcer, and it protects the stomach by three mechanisms. One, it inhibits the proton pump, so there is less secretion of hydrochloric acid. When acid secretion is less, there is less chance of peptic ulcer. Second, prostaglandins increase the production of mucus and bicarbonate layer. So prostaglandins increase mucus and bicarbonate. So when protective layer is more, there will be less risk of peptic ulcer. And third very important thing is prostaglandins cause vasodilation. So that will increase the blood flow to the gastric mucosa. Increased blood flow will help in removing the inflammatory mediators. So in short, prostaglandins are protecting the stomach. So that's why if prostaglandins are not there, there is increased risk of peptic ulcer. So that is the main problem with the COX inhibitors. So cyclooxygenase inhibitors like aspirin, they are also known as non-steroidal anti-inflammatory drugs. They can lead to peptic ulcer. So that peptic ulcer is called as NSAID, non-steroidal anti-inflammatory drug induced peptic ulcer. So this type of peptic ulcer is due to less prostaglandin. So we can give prostaglandin to treat this peptic ulcer, and the drug we can use is misoprostol. Misoprostol can be used for NSAID induced peptic ulcer, but important to remember, it is a selective drug for NSAID induced peptic ulcer, but it is not the drug of choice, because for drug of choice the drug should be very safe also, effective as well as safe. Drug of choice for every peptic ulcer, including NSAID induced peptic ulcer, drug of choice is always proton pump inhibitors. We will discuss in the GIT. Even for NSAID induced peptic ulcer, drug of choice are PPIs. So that is about the effect of prostaglandins on the stomach. Now lastly, prostaglandins, they are also present in the eye. Particularly we have PGF2 alpha. And the function of prostaglandin F2 alpha in the eye is to increase the uveoscleral outflow. So that means prostaglandin F2 alpha increase the drainage of aqueous humor. So we can utilize PGF2 alpha in treatment of glaucoma. And the drug which is used is latanoprost. In fact, latanoprost is drug of choice for primary open angle glaucoma now. Latanoprost is drug of choice for primary open angle glaucoma. The major side effect of latanoprost you can remember. It is prostaglandin F2 alpha. The main side effect of latanoprost are P for pigmentation of iris. Iris pigmentation. The term for iris pigmentation is heterochromia iridis. It causes iris pigmentation called as heterochromia iridis. And then it causes G means growth of eyelashes. Growth of eyelashes, which is called hypertrichosis. Hypertrichosis. So heterochromia iridis and hypertrichosis are the adverse effects of latanoprost. So these are the important points regarding the prostaglandins. Earlier we discussed about prostaglandins, how they are synthesized and what are their functions. Now we will discuss the drugs which can inhibit the formation of prostaglandins. So if we revise, prostaglandins are formed from phospholipids, membrane phospholipids, which are metabolized to form arachidonic acid with the help of enzyme phospholipase A2. This arachidonic acid can be acted upon by cyclooxygenase to form prostaglandins and by lipooxygenase to form leukotrienes. So if we inhibit cyclooxygenase enzyme, prostaglandins will not form. If we inhibit phospholipase A2, prostaglandins and leukotrienes both will not form. The drug which inhibit phospholipase A2 enzyme, which is a rate limiting enzyme in formation of prostaglandins and leukotrienes, the drug inhibiting this are steroids. And we know prostaglandins are involved in causing inflammation. So we can say they are steroidal anti-inflammatory drugs. On the other hand, if a drug inhibits cyclooxygenase enzyme, chemically they are not steroids and they are acting at one level below the steroids. These drugs are also anti-inflammatory because prostaglandins are not produced. So these drugs are called as non-steroidal anti-inflammatory drugs, NSAIDs. So here we will mainly focus on non-steroidal anti-inflammatory drugs. Steroids we had already covered in endocrine system. Now we discussed non-steroidal anti-inflammatory drugs act by inhibiting the cyclooxygenase enzyme, and we have two types of cyclooxygenase enzyme, COX-1 and COX-2. The basic difference between the two is important to remember. COX-1 is constitutive enzyme or housekeeping enzyme. The meaning of this is the prostaglandins which are normally required in the body, they are produced by COX-1. Whereas COX-2 is inducible enzyme. Inducible enzyme means COX-2 will form prostaglandins where inflammation is there. So at the site of inflammation, there is induction of COX-2 formation, and COX-2 will result in formation of prostaglandins, and that will cause inflammation. So in simple language, we can say COX-1 do all the good functions, whereas COX-2 do all the bad functions. So COX-1 is hero and COX-2 is villain. But the difference is not so clear nowadays. What is found nowadays is even COX-1 can be induced at site of inflammation, although at less, but it can be. So COX-1 also plays a part in inflammation, whereas COX-2 is also normally present at some places, and these places are kidney, endothelium and brain. So kidney, endothelium and brain normally contains COX-2 also. The basic concept remains same, that COX-1 do most of the good functions, whereas COX-2 do mostly inflammation. So if we want to treat inflammation, we will like to inhibit COX-2 So we initially developed the drugs which were non-selective COX inhibitors that can inhibit both COX-1 and COX-2. But later on, we developed the drugs which were selective COX-2 inhibitors. So non-steroidal anti-inflammatory drugs we can grossly classify into non-selective COX inhibitors and selective COX-2 inhibitors. The basic difference between these two drugs will be non-selective drugs, they will also inhibit COX-1. That means they can interfere with normal functions also. And most important function you need to recognize is prostaglandins, particularly prostaglandin E2 protect the stomach. So when we inhibit COX, prostaglandin will not be produced in the stomach, so there will be no protection. So person will be predisposed to peptic ulcer. So non-selective COX inhibitors, they increase the risk of causing peptic ulcer, whereas there is less chance of causing peptic ulcer with non-selective COX-2 inhibitors. Non-selective COX inhibitor increase the risk of peptic ulcer. It is lesser with selective COX-2 inhibitors. Now starting with non-selective COX inhibitors first. The examples of the drugs inhibiting COX-1 and COX-2, these are aspirin, paracetamol, which is also known as acetaminophen, then ibuprofen group of drugs, ibuprofen, flurbiprofen like drugs. Then we have diclofenac like drugs, diclofenac, aceclofenac, these are the drugs. We have indomethacin, mefenamic acid, then we have drugs like piroxicam, phenylbutazone is another drug. So these are some examples of non-selective COX inhibitors. The important points regarding these drugs, all of them inhibit COX-1 and 2. So all of them can be used for fever, pain, and inflammation. And all of these drugs can predispose to peptic ulcer disease. That is common to all of them. Now, special point regarding individual drugs to remember. Piroxicam is very long-acting NSAID. Because of enterohepatic cycling, it is utilized again and again, so it is very long-acting. Indomethacin can produce sedation, so it should be avoided in person requiring constant attention. Ibuprofen, this is the only anti-inflammatory drug which is approved in children. So anti-inflammatory drug of choice, non-steroidal anti-inflammatory drug of choice in children is ibuprofen. Now we are left with the two most important drugs. One is aspirin and second is paracetamol. So we'll discuss these one by one. First we'll discuss about paracetamol or acetaminophen. Now paracetamol, it is the only NSAID which has no anti-inflammatory activity. Means other NSAIDs have antipyretic, analgesic and anti-inflammatory activity, whereas paracetamol only has antipyretic and analgesic activity. It does not possess anti-inflammatory activity. Now to explain this, why it does not have anti-inflammatory activity, a theory was made. That theory was called as peroxide theory. Peroxide theory. So according to this theory, paracetamol become inactive in the presence of hydrogen peroxide. At the site of inflammation, there is formation of large amount of hydrogen peroxide. So paracetamol is not able to work. Whereas at other places like in the brain or for the fever or for the pain, hydrogen peroxide is not generated. So paracetamol keep on working. So peroxide theory could explain that paracetamol does not have anti-inflammatory activity. But this theory could not explain the second finding that paracetamol has negligible risk of causing peptic ulcer disease or GIT toxicity. Although it is a non-selective COX inhibitor, but it has less risk of causing peptic ulcer disease. To explain this finding, another theory was proposed, and that theory was called as COX-3 inhibition theory. It is assumed that paracetamol does not inhibit COX-1 or COX-2. Rather, it inhibits another variant of the same enzyme, which is called COX-3. COX-3 is mainly present in the CNS, and we know CNS can control pain and fever, but inflammation is a peripheral component. So it has no effect on inflammation, but it can control fever and pain. Similarly, in the GIT in the stomach, which is a peripheral area, this does not work, so it has less risk of causing peptic ulcer disease. So this is one important thing about paracetamol. It does not possess anti-inflammatory activity. Although paracetamol is also approved in children, but remember paracetamol is used for fever and pain only, whereas anti-inflammatory drug, if we want to use in children, it has to be ibuprofen.
There is one more theory to explain the analgesic mechanism of paracetamol. And this theory that a metabolite of paracetamol, it acts by stimulating vanilloid receptors. There are a receptor known as transient receptor potential vanilloid, TRPV. It is assumed that the metabolite of a paracetamol may act through this receptor to produce the analgesic effect.
Another important finding about paracetamol is paracetamol, most of it become inactive. Almost 99% you can say becomes inactive after metabolism. But a very small amount of paracetamol, you can say around 1%, it is converted to a compound called as NAPQI. The full form is N-acetyl para-amino benzo quinone imine. N-acetyl para-amino benzoquinone imine, and this reaction is catalyzed by a microsomal enzyme. CYP enzyme or microsomal enzyme catalyze this reaction. Now, this NAPQI which is generated, it has very high affinity for sulfhydryl groups. That means wherever it will find the sulfhydryl group, it will bind, and that can cause problem. We know that sulfhydryl group are present in important biomolecules like DNA, RNA, proteins, enzymes. Lot of substances contain sulfhydryl group. So when we give paracetamol, it will generate NAPQI, and this NAPQI can cause damage. But we know paracetamol is very safe drug. So although it is producing NAPQI, still it is very safe drug. The reason is our liver, it produces glutathione. Liver produce glutathione, and glutathione we know is a tripeptide. It contains 3 amino acids, one of which is cysteine, and we know cysteine is a sulfur containing amino acid. That means it contains sulfhydryl group. So whatever NAPQI is generated, it will bind to glutathione and become inactive, neutralized. So that means NAPQI is not available to bind to any important molecule. So paracetamol is very safe. Now paracetamol toxicity can occur in 2 circumstances. One, the NAPQI generated is too high. NAPQI generated is much more than glutathione can neutralize. So that will be seen in overdose. So if a person takes large amount of paracetamol, accidental poisoning can occur. Glutathione become the limiting factor. Second, if liver is not working properly, it will produce less glutathione. When less glutathione, less ability to neutralize NAPQI. So one, overdose. Second, liver disease. Now third important reason is if a person is having both of them, and both of them are likely in a patient who is chronic alcoholic. But a chronic alcoholic is likely to have a liver disease, alcoholic liver disease. So less production of glutathione. Second, chronic alcoholism is a CYP inducer, microsomal enzyme inducer. So in a normal person, most of the paracetamol is conjugated and become inactive. But if CYP is induced, this ratio can change. So instead of 99%, 90% will form inactive compound, but instead of 10% can form NAPQI. So same amount of paracetamol generate more NAPQI, and NAPQI cannot be neutralized because liver is not working properly. Less production of glutathione is there. So chronic alcoholics are at increased risk of toxicity to paracetamol as compared to normal person. And in overdose, paracetamol causes liver damage. So how to treat toxicity? Remember, the NAPQI, it is binding to sulfhydryl groups. So if we give sulfhydryl group from outside, NAPQI will dissociate from the important biomolecules and we can reverse the poisoning. So how to provide an sulfhydryl group from outside? It is by giving a drug called N-acetylcysteine. N-acetylcysteine. It is antidote for paracetamol poisoning. It provides the necessary sulfhydryl groups that will neutralize the poisoning. So N-acetylcysteine is drug of choice for paracetamol poisoning. So these are the important points regarding paracetamol. Now moving to the last drug in this category, which is aspirin. We all know aspirin is acetyl salicylic acid. Now important point about aspirin to remember, among all the COX inhibitors, aspirin is the only one which is irreversible inhibitor. All other are reversible inhibitors. Aspirin is irreversible inhibitor. And due to its irreversible action, it has another use apart from the three uses: fever, pain, inflammation. It has fourth use, antiplatelet drug. We discussed earlier in prostaglandins also, aspirin can be used as antiplatelet drug. Now second, aspirin is contraindicated in children with viral illness because of development of a syndrome called Reye syndrome. Aspirin should not be given to child with viral illness because of risk of development of Reye syndrome. Aspirin can cause Reye syndrome. Third important thing, aspirin can cause hyperuricemia at therapeutic doses. Although in high doses, very high doses which cannot be tolerated therapeutically, aspirin can cause excretion of uric acid, but that is clinically not relevant. But clinically important finding, at therapeutic doses it causes hyperuricemia. So it is avoided in gout patients. So that are the important points regarding aspirin. Now in aspirin poisoning, what happens if a person take overdose of aspirin? The condition is called as salicylism. Salicylism. So what aspirin does is, in overdose, aspirin stimulates the respiratory center of the brain. So when respiratory center is stimulated, there will be hyperventilation. Hyperventilation. And this hyperventilation, it will result in more intake of oxygen and more removal of carbon dioxide. So that means there will be excessive removal of carbon dioxide, which will become less in the blood. And when carbon dioxide is less in the blood, it will cause alkalosis. Remember, carbon dioxide combined with the water to form carbonic acid means it helps in generating the acidic medium. So when carbon dioxide is less, it results in alkalosis. Because it is due to respiratory problem, so it is called respiratory alkalosis. So till respiratory alkalosis, aspirin poisoning is reversible. That means if we stop giving aspirin, it will reverse back. Salicylism is reversible aspirin poisoning. Now suppose we do not stop aspirin and we continue to give aspirin. Now this respiratory alkalosis will be converted to metabolic acidosis. Now why this happens is, number one, when there is respiratory alkalosis, it will be compensated by metabolic system. That means kidney will start removing bicarbonate in the urine. So when bicarbonate is removed in the urine, it becomes less in the blood. The medium will start becoming normal, neutral. From alkalosis, it will start becoming normal pH. Second thing, because of hyperventilation, the person has to take breath strongly. That means the muscles will tire, and when the muscles tire, there is accumulation of lactic acid. So one acid is accumulating, bicarbonate is getting removed, acid is getting accumulated, plus we are continuing to give aspirin, which is also an acid, acetyl salicylic acid. So due to all these reasons, acidosis occurs, metabolic acidosis, and metabolic acidosis is irreversible. It will not automatically treat, and this is very dangerous. The person can develop severe dehydration. So we need to treat metabolic acidosis, and obviously to treat acidosis we will give sodium bicarbonate. And if you remember, sodium bicarbonate will also make the urine alkaline, and in alkaline medium acidic drug will not be reabsorbed. So aspirin will not be reabsorbed, so it will be excreted. So sodium bicarbonate serve two functions. One, it reverses the metabolic acidosis, and second, it helps in excretion of aspirin from the body. So sodium bicarbonate is the mainstay in treatment of aspirin poisoning. So these are the important points regarding the non-selective COX inhibitors. Common points revising again. Non-selective COX inhibitors, they are having three uses: fever, pain and inflammation, but they increase the risk of peptic ulcer. So to avoid this problem of GI toxicity or peptic ulcer, we developed selective COX-2 inhibitors, and the name of these drugs end with coxib. The drugs like celecoxib, rofecoxib, valdecoxib, etorecoxib, parecoxib, and the latest one is lumiracoxib. So coxibs, the advantage over non-selective drug is they are lesser risk of GIT toxicity as compared to non-selective drugs, but they have even bigger disadvantage. They increase the risk of myocardial infarction and stroke. They increase the risk of thrombotic disorders. So because of this risk, which is even more dangerous than GI toxicity, these are not the first line drug. So whenever we want anti-inflammatory drug, we will prefer the non-selective drugs. But when they are not tolerated due to GI toxicity, we will shift to selective COX-2 inhibitors. In fact, rofecoxib and valdecoxib have been withdrawn from the market because of these side effects. But this is a group side effect, all of them can predispose. Etorecoxib is the longest acting among the selective COX-2 inhibitors.
Parecoxib is given by parenteral route, whereas lumiracoxib is had been withdrawn because of hepatotoxicity. So you can remember L for liver dysfunction, liver damage. So lumiracoxib withdrawn because of hepatotoxicity, and parecoxib can be given by parenteral route. Then there are some drugs which are called as preferential COX-2 selective inhibitors. Preferential COX-2 selective inhibitor, basically this is the term given to those drugs which inhibit COX-2 more than COX-1. So they are intermediate between non-selective COX inhibitors and selective COX-2 inhibitors, but this is only the theoretical thing, but practically they are assumed to be just like the non-selective COX inhibitors. And the name of these drugs you can remember as the men. the men, diclofenac, meloxicam, etodolac, and nabumetan. So these are considered preferential COX-2 selective inhibitors, but practically they are having same functions as non-selective COX inhibitors. Okay. So these are the important points regarding the non-steroidal anti-inflammatory drugs.